Can you hear me clearly?
Yes.
Great. All right, Jay, thanks for the wonderful introduction and for the invitation. Hopefully our audience will enjoy it. Today we'll be discussing dehydrated amnion grafts, their indications and pearls for success. Try to give you my 5 cents. These are my relevant financial disclosures, the relevant one being that I am a consultant for ISP Surgical, who produces AmnioTek. So I actually want to start by presenting a case. This is a 46-year-old male following multiple ocular procedures, including a pars plana vitrectomy for retinal detachment and a deep anterior lamellar keratectomy for keratoconus. He ended up developing this persistent epithelial defect that kept on going for 4 weeks, despite optimization of the ocular surface and placement of a therapeutic bandage contact lens. He had no history of cold sores or herpes. So let's shift this talk to amniotic membrane now. Amniotic membrane is a semi-transparent tissue generated from the innermost layer of the placenta, and it contains a thick basement membrane with an epithelial and stromal side of similar composition to that of your cornea and conjunctiva epithelium. The mechanical support has bioactive properties such as promoting adhesion and migration of the epithelial cells and anti-inflammatory properties, rendering it an elementary part of ocular surface reconstruction. Now, remember, the amniotic membrane can be placed so that either the epithelial side or stromal side faces up away from the host cornea. Now, indications for amniotic membrane and their use have broadened over the years, and they're now successfully used to treat persistent epithelial defects, non-healing corneal ulcers, severe dry eye, descemetocele, symptomatic bullous keratopathy, and small corneal perforations. It can also be used as part of surgical reconstruction during limbal stem cell transplants, pterygium, large neoplasias, strabismus, and glaucoma filtration surgery. And you have different types of amniotic membranes, which are all harvested in a similar fashion. The placenta is washed with sterile antibiotic solution. The amniotic membrane is then separated from the chorion and then spread on nitrocellulose filter paper, stromal side down, and cut into appropriate sized pieces. The tissue can then be cryopreserved, freeze-dried, or air-dried. Tissue obtained from eye banks is usually fresh frozen amnion. Commercially available cryopreserved products include the Procera and AmnioGraft. Recently, several commercial products have become available where the amniotic membrane is dehydrated, such as AmnioTek, which we will be discussing today. Now, a bit about AmnioTek sutureless amniotic dehydrated amnion and how it's manufactured. It uses a patented processing technology maintaining a continuous intact epithelium, basement membrane, compact and fibroblast layers of the amniotic tissue. This process has also been reported to maintain the presence of cytokines and growth factors with particularly high quantities of EGF, PDGF, TGF, TIMPs 1 and 2. Now, the AmnioTek has several key features which give it advantages over other products available on the market. Unlike the Procera, which you may be familiar with, it does not require a fixation ring. When applied to a dry surface, it sticks adequately to the cornea and then is kept in place with a simple and readily available standard bandage contact lens. Unlike cryopreserved tissue, it can be stored at room temp for months or even years. It's very thin, approximately 40 to 60 microns, and is semi-transparent as demonstrated in the photo on the right. Require any sutures and can be performed in office with the patient sitting in an office chair bent slightly backwards. But the question is it efficient? Well, we recently published in the AJO some of our experience with dehydrated amniotic membrane for persistent epithelial defects. We shared our outcomes, and we included 9 eyes of 8 patients with an average age of approximately 55 years and a range of 38 to 73 years, all across the board. The follow-up time of these patients ranged from 3 months to nearly a year. In all cases, we found that the amnion was absorbed completely within approximately 2 weeks. Resolution of the persistent epithelial defect was achieved in approximately 90% of patients. That's nearing the success rates of a torzoraphy even. Time to epithelial defect resolution from the placement of the amnion was approximately 18 days, which was significantly less than the duration of the defect prior to placement of the amnion. The one case that was not resolved following amnion is currently awaiting limbal stem cell transplantation. And in terms of visual acuity, it's significantly improved from 20/170 Snellen to 20/47 Snellen. And this is a picture of that same patient that we showed earlier in the talk. You can see here that they have this persistent epithelial defect. This is what they look like with the amnion in place. And by 2 weeks, the persistent epithelial defect completely healed. Now, this is a case of a young female with a persistent epithelial defect due to a damaged ocular surface following Stevens-Johnson syndrome. Her ocular surface is meticulously dried, and that's critical for it to stick properly to the cornea. The amnion is carefully removed from the packaging in correct orientation and placed onto her dried cornea with simple jeweler's forceps. A dried bandage contact lens is then placed on the eye. You really want to make sure to get that bandage lens as dry as possible before placing it on the eye, otherwise the amnion can curl up. This is an example of a patient with a persistent epithelial defect in his PKP graft. He failed treatment with a bandage contact lens and a tarsorrhaphy and was offered a dehydrated amnion. We identified correct orientation of the amnion with the red sticker and carefully removed from the packaging with a non-tooth forceps. The patient's double bolstered tarso is spread open temporarily. His ocular surface is dried meticulously, and then the amnion is quickly placed and flattened before it folds on itself. Again, we really want to dry the surface and the bandage contact lens before placing it. Otherwise, it can curl upon itself. And at the end of the procedure, we carefully remove the speculum. And you'll see that we tightened the tarsorrhaphy on top of all that in the end. So this was actually a pre-placed tarsorrhaphy. So this patient has the dehydrated amnion, a bandage contact lens, and a tarsorrhaphy because they had not responded well to the bandage contact lens and tarsorrhaphy alone. Now, this is a case of a patient with limbal stem cell deficiency and Salzmann nodule seeking comfort. I knew this patient for the previous year. They had extreme discomfort that was not responding to anything else. They had this limbal stem cell deficiency in both eyes and were not candidates for an autologous stem cell transplant, and they were not interested in receiving a stem cell transplant from a donor, as they were not interested in having long-term immunosuppressive therapy. So our goal here was actually just to add to her comfort. So we offered to perform a superficial keratectomy and place an amnion with the main goal of improving comfort. The goal here was to remove all of her lesions with a superficial keratectomy. Now, since she has limbal stem cell deficiency, we know that the healing time would be excessively long, and it's going to take her a long time for that epithelial defect to heal. So we were hoping to shorten the healing time and increase comfort after the painful procedure by placing the amnion. Now, we did want to get rid of all that conjunctivalization that she had on the cornea to make sure that the amnion sticks properly. You'll see here that at the end, we make sure to dry all of the heme and the fluid carefully with the Weck cells. And once we're satisfied that the ocular surface is dried enough, we carefully remove the amnion from the package, making sure that we're looking at the red sticker and we maintain the correct orientation. Then we carefully place it on the ocular surface. You see, as we near the ocular surface, it just smells the humidity and wants to start curling up. So you got to place it quickly and then use 2 instruments to kind of flatten it out on the cornea. There's a bit of heme there, no problem. We can remove that with a Weck cell. We then meticulously dry our bandage contact lens. I'm going to repeat that several times in the talk, because if you do not do that and you place the bandage contact lens wet, it'll scroll up everything. You want to get rid of any of those air bubbles underneath that bandage contact lens. And once you're satisfied with that, you can then carefully remove the speculum. So this is that same patient that had that nasty ocular surface. This is 2 weeks after treatment. There's no epithelial defect. There's a much smoother ocular surface and optical surface. Her eye is much quieter. And the most important thing is that the pain is, for the most part, relieved. You can see as well that the amnion is completely absorbed. Now, here's a case of a patient with exposure keratopathy and progressive melting of his inferior cornea. They had approximately 10% left of their corneal thickness And we basically defined them as an impending perforation. You can see that right here. This little nick here has got 10% of their tissue left. Now, it is a peripheral lesion, so their vision actually isn't too bad. It's better than 6/12. It was 6/9, if I'm not mistaken. So when we offered them the glue, to glue it, they weren't keen on it, since we did explain to them that gluing it with histoacryl could in fact worsen their vision and could cause pain since it's near the limbus. And they weren't keen on the idea of having that glue in their eye for a long time and having a bandaged contact lens in their eye for a long time. So we did discuss with them the option of combining.
Mau bikin kapan? Besok pagi.
Oh, sorry about that, Jay. Would you mind helping with the mute there? Thanks. We did discuss with them the option of combining the.
Itu pertanyaannya Pak mau kerjain kapan? Gitu aja pertanyaannya. Dari tadi udah disuruh.
Hi there, Dr. Lutfi Amiada. How are you? Oh, there we go.
Sorry.
It's okay. No worries.
Okay.
All good.
Can you mute yourself, please? Thank you.
So we discussed with them the option of combining amnion together with tarsorrhaphy with the idea of trying to avoid gluing it and of course avoiding a perforation. And here's the video. So in this case, we started by pre-suturing the tarsorrhaphy, and we did this to avoid having heme on the amnion and manipulating the ocular area while the amnion was freshly placed on the eye. And after we threw the tarsorrhaphy, we spread it wide open. And now we're going to dry with wet cells the ocular surface. And I did choose to debride a bit of the surrounding epithelial ridge to aid with the reepithelialization. And then remember, when going with the amnion near the ocular surface, you're going to see it begin to curl right there. You see it wanting to curl inwards. So you really have to place it quickly and spread it out with two instruments. I wanted to make sure I was covering the area of the epithelial defect and the thinning, and it's really well covered there. And again, after it's spread out and sufficiently dry the bandage contact lens and only then place it on the amnion graft. And now, you know, it's easy to finish off the case. We just tighten our pre-sutured tarso and we can finish the case quickly. So this is 2 weeks following treatment, and you'll see that the amnion has actually completely absorbed and integrated into the tissue. The epithelial defect has resolved, and the thickness in that area where there was 10% left of cornea is now gone back to around 40 or 50%, and the visual axis is still clear, and the patient has maintained their visual acuity, so they were quite happy with that. Here's another case we recently performed where a patient with Saltzman nodules secondary to EBMD, epithelial basement membrane dystrophy, underwent a superficial keratectomy combined with amnion and a bandaged contact lens at the end of the procedure. Following our routine careful superficial keratectomy, the ocular surface is again meticulously dried with several wet cells. You really want to make sure everything's dry before placing the amnion. And again, notice how it wants to scroll once it starts to smell that humidity. So you really want to flatten it out as quick as possible with two instruments. Then we leave it in place to dry for another couple of minutes and place our dry bandage contact lens on top of it. And really, it's quite amazing. That's all you need to keep it in place. No sutures necessary, in-office procedure, home that same day. Bandage contact lens on the eye, dry. I think you've seen enough of that. So with that being said, not everything is picture perfect. I'm going to show you a couple of curveballs. Here we have a case that amnion seems to be absorbing really slowly and perhaps integrating itself into the cornea. And this is a patient which actually received that dehydrated amnion for a persistent epithelial defect after cross-linking. And this is a month after the amnion. And we think that this may be the result of placing the amnion with the stromal side facing down. And we always advocate, and I believe the company does that as well, placing its stromal side facing up. Yes. And you can identify the correct orientation of the amnion by looking at the red sticker on the packaging. And with the AmnioTek, it's really comfortable because you have those two little pieces that stick out, and you want the thicker one clockwise compared to the thinner one. And that way you know you're in correct orientation. But just in case, you can just look at that red sticker and just maintain that same orientation, and you know that you're good to go. Now, In terms of expanding indications for dehydrated amnion, we've started to use it prophylactically, so to speak, for specific indications. For instance, we've had 2 cases of patients with neurotrophic corneas and a secondary band keratopathy. And in those cases, following the superficial keratectomy combined with EDTA, we applied the amnion at the end of the cases to help improve the regenerization of the epithelium, because these cases tend to be very slow healers. And in both cases, following absorption of the amnion, within 2 to 3 weeks, there was no epithelial defect gone. In addition, we've had 2 cases of patients with bullous keratopathy and blind eyes referred for recalcitrant pain. And these cases, we can offer patients epithelial debridement combined with anterior stromal puncture and a diamond dust burr to try to intentionally cause scarring of the anterior stroma. And this is followed by placement of an amnion to try to improve the epithelialization and to reduce pain. In 2 cases, we had complete resolution of symptoms. And the third, we had a persistent peripheral edema, which led to discomfort. Probably I could have done a little bit of more burr and anterior stromal puncture in the periphery to avoid that, but the amnion did help speed things up. Finally, we've used this prophylactically in 2 cases of patient undergoing epithelial debridement for recurrent corneal erosions. The reason being is that there were concerns about their healing due to background diseases such as insulin-dependent diabetes. In both cases, resolution of the defect was identified after the amnion was absorbed within 2 weeks. Now, this is a nice take-home slide regarding all possible modalities when it comes to ocular surface optimization. You can call this the ocular surface optimization toolbox. These include lubricants, anti-inflammatory options, nutritional support, lid margin management, and adjuncts, important adjuncts such as dehydrated amniotic membrane. Now, a few take-home points. I do think that you should use it earlier, prior to scarring for cases with persistent epithelial defect. We know that if you have those defects for a longer amount of time, you're definitely going to have some hazing scarring in those areas. If we can speed up the epithelialization with an amnion, we can help avoid that. This is a quick procedure that does not require any sutures. It can be done in office. The lack of necessity of sutures means less follow-up visits for the patients because you don't have to remove sutures. And this seems like a huge advantage in the COVID era. Patients aren't keen on coming to the office and waiting in a waiting room with a lot of other patients. There's faster return to vision compared to a torzoraphy or an amniotic membrane from the eye bank. The amniotic membranes we get from the eye banks can take several weeks sometimes to absorb, especially in uninflamed eyes, whereas these dehydrated amnions can absorb themselves within 2 weeks. And regarding a torzoraphy, patients often aren't keen on the idea of having their eyelids sutured shut. A few tips. I do recommend taping the patient's mask before placing it, since sometimes their breath and its humidity can cause it to curl up. And I do recommend meticulously drying the cornea surface and the bandage contact lens to avoid curling of the disc. Thank you for tuning in and listening to me, and hopefully you've enjoyed this talk on dehydrated amnion grafts.
Michael, thank you very much. That was great talk. Thank you so much. And if you have questions for Dr. Michael, I don't know how much longer we actually have you, doctor, because I know you're in clinic, but we can move on to Dr. Harvey's lecture. But if there's a burning desire, if you want to ask Dr. Michael something, you can unmute yourself and please have at it.
Yeah, I've got 10 minutes for you.
All right.
I'm happy to.
Sure.
I can start. I see that someone says, how long do we keep the bandage contact lens on? They're asking that in the chat box. Great question, Dr. Agama. I would say that I would definitely keep it on as long as the amnion has not been absorbed. From my experience, it can absorb itself within anywhere between 10 days to 2.5 weeks. The average is 2 weeks, but I would not remove it until it's been absorbed, because even after a week, if you take the bandage contact lens off and it still hasn't completely absorbed and someone forcefully blinks and they have a dry ocular surface, they may dislodge it. So I'm not worried about that. When can we do placement of amnion as an office procedure, and when do we do in the OR? That's a great question from Dr. Karuna. I would say that since this is a sutureless procedure, I think you can easily do it in office if you don't have any additional combined procedures you're doing as well. I mean, if you're doing a superficial keratectomy At the same time, I do think that's something you want to do in a sterile environment. Or for instance, if you're throwing a tarsorrhaphy as well, then you may want to do that as well in a sterile environment. But for the large part, if it's just a persistent defect, that would be a classic example of when you can just place it in office. Another classic example would be for these refractory dry eye patients that don't respond to anything else, and they can sometimes benefit from the amnion as well. We've had a handful of cases as well, which really did not respond to anything other than a dehydrated amnion, and they come in monthly to get those. It can be an economic burden, but maybe that's something that Jay can help work out. I do think that some of these dry eye patients can definitely benefit from it. Sometimes getting even one can sometimes kind of reset their system and have a lasting effect. So I hope that answers your question, Dr. Karuna. We have a question from Dr. Farida, who's asking when do we need to do tarsorrhaphy? Now, that's an excellent question. That patient, where you saw me do a pre-sutured tarsorrhaphy combined with an amnion, they actually had exposure keratopathy because they had an ectropion from what looks like perhaps the beginning of a squamous cell carcinoma in their lower lid. So my concern was that since the actual culprit is the ectropion, then simply putting the amnion isn't going to help, because that's going to come back once the amnion is absorbed. So I did want to put in a tarsorrhaphy to try to help lift up that lower lid as well. Ultimately, they will need to address that ectropion to, for a definitive answer. So that's why I felt safer having that pre-sutured tarsorrhaphy. The second case where you saw the patient on tarsorrhaphy, they had actually not responded to tarsorrhaphy, but since the sutures were already there, we just spread it open, put in the amnion, and sutured it back. But I will say that in the majority of cases for the persistent epithelial defects, just placing the amnion itself was enough. So yeah, so I would put the tarsorrhaphy in if you think that the actual cause requires it, such as exposure and things like that, exposure secondary to ectropia and things like that. What happens if you place the amnion on the other side? So I don't see the full name. Oh, I see Dr. Correa asked that. Great question, Dr. Correa. So if you saw there was a patient that had an intact that seemed to have this remnant amnion in the cornea. So what I think what happens is that if you have the stromal side facing down and then you have stroma touching stroma, then I think it kind of just incorporates itself into the stroma rather than absorbing itself. And that's why I would recommend avoiding that. I don't think you're at risk for infection or things like that. And I do think that the epithelial defect will still heal, but I do think you'll get more of like a hazy appearance. So that's why in general, we do advise having the epithelial side down and the stroma facing up. Basically, just to keep it simple, just look at the red sticker, maintain that orientation. And the nice thing about the AmnioTek is you have these two ridges sticking out, a thick one and a thin one. And you can maintain orientation by making sure that your thick one is clockwise compared to the thin one when you're looking at it. So I think that's very convenient. Yeah. We have a question from Dr. Fatma. How long do you keep the bandage contact lens in place? So that's actually similar to what Dr. Agama asked. I would keep it in at least until the amnion is absorbed. That's usually around 2 weeks, sometimes 2.5 weeks, sometimes less, 10 days. That's and of course, make sure that the epithelial defect has actually healed itself. From my experience, it's a 90% success rate with epithelial defects. Great question.
Dr. Michael. Okay. Thank you, Dr. Michael.
My pleasure. Great questions.
I think we got to switch this over. Can you help us switch this over to Dr. Harvey?
Oh, sure.
I think, can you see my slides?
Yep.
All right. So great talk, Michael. And I'm going to echo some of the points that Dr. Michael very elegantly discussed, as well as talk about other applications of the dehydrated amniotic membrane. And we've been using the dehydrated amniotic membrane for almost a decade now. Can you believe it, Jay?
I know.
And we're finding more and more applications for it, which we'll discuss. So I won't go much into this, but just to echo that the amniotic membrane does have both tissue healing and anti-inflammatory properties, and that it can be used for a wide variety of conditions. The mechanisms of action include structural effects, where it protects the epithelial surface from exposure and provides a scaffold for growth, regrowth of epithelial cells. So you can think of it as acting like a biological bandage, but there are also some physiological effects, as Dr. Michael explained earlier. There are anti-inflammatory cytokines and anti-angiogenic factors that can be used to prevent scarring and vascularization. These are some of the many corneal and conjunctival diseases that you can apply amniotic membranes on, and we'll show you some examples later. When I came back from a fellowship in 1998, I actually started preparing cryopreserved amniotic membranes in St. Luke's Medical Center. And we were using this for a time, but we encountered a lot of difficulties. First, you had to find a donor, you had to harvest it, you had to prepare it, then you had to store it. And all of these difficulties limited the accessibility of fresh or cryopreserved membranes. Plus, it was hard to apply these membranes because you would have to suture it. Now, when I was introduced to the dehydrated membranes by Jay, we saw immediately the benefits of using this product. First, you don't need a specialized freezer. You can store it at room temperature in your clinic. Secondly, you can transport it. It comes in a box, so you can just bring it anywhere where you might see patients. And this is good for doctors who actually practice in several locations, with some locations outside of, for example, a big city. And as Dr. Michael explained earlier, there's no need for suturing. You know, a lot of these patients, they want, they come to you with, they're in a lot of pain, and if you put a fresh membrane and you have to put in stitches, that actually causes more pain. So by using the sutureless technique, you can actually give patients some relief. So let's show some more examples of the amniotic membrane as used in ocular surface disease. And we done a case series of eyes, and this is the, we normally do this in office, as Dr. Michael showed in his videos. We put topical anesthesia, we sterilize the field with povidone iodine drops. You can open the eyelids for cooperative patients. You can, you don't actually need lid retractors, but lid retractors can make it easier if you're starting with this procedure. If the epithelium is diseased, you may want to consider debridement. It also helps the amniotic membrane stick better. And in addition to having a dry membrane, doing epithelial debridement also helps the membrane stick better onto the ocular surface. You can use forceps, any simple forceps, to apply the membrane on the ocular surface. And then you apply the bandage contact lens, and we normally give these patients antibiotics or anti-inflammatory drops, and usually we would remove the bandage contact lens after between 2 to 3 weeks. So we found also that some patients, when you apply the amniotic membrane, because it's translucent, sometimes they will have poor visibility until the amniotic membrane dissolves. And some of our patients, they have only one eye left that's seeing. And the AmnioTek people are very nice to have fashioned this amniotic membrane vision, which actually has a central hole, which allows patients with one eye only to see out of this hole. So they're not as incapacitated compared to these amniotic membranes without any holes. The key is to position that hole either at the pupil or slightly above it. The product list of ISPs are constantly expanding, and they've come up with this all-in-one kit, which we like to keep in our outpatient clinics, because all of the instruments you need for applying the membrane are there, including the forceps, the Wexel sponges, and the bandage contact lenses. So this is just showing you how to do Wexel keratectomy as described by Dr. Ken Kenyon. So by doing this, you can increase the tackiness of the corneal surface, and makes the amniotic membrane stick better, so it doesn't move around too much or curl too much. So you can use a dual blade lid speculum, and the applying the amniotic membrane. See, as when there may be some curling, but if you can be careful, you can actually apply it even if it starts to curl. The key is just to do things a bit quickly so it doesn't curl too much. And then you apply the amniotic membrane, you apply the bandage contact lens over it. Okay, the hardest part actually is removing the dual blade lid speculum. So you have to be very careful when you do this, because sometimes you could displace it. So it's fairly easy to put in the amniotic membrane, and it's fairly easy to put the contact lens, but the hard part really is removing the dual blade lid speculum. And if you're not careful, you'll displace the whole thing. So you have to do it again. Here you can see an in-office procedure using the AmnioTek C Vision. So this is the one with the hole. So this is a one-eyed case. So we wanted to have the patient to still have good visibility, and perhaps because he only had one eye, he had an industrial accident. He spilled chemical over his eye. So you can see once you put it on, you try to tack it down, and then you put the bandage contact lens. And one good thing about using your fingers to open the eyelids is that you don't have to worry about displacing the lens. And you can see here, the hole is actually right over the pupil. So the patient still has decent vision after implanting this, after placing the amniotic membrane. So we've been using this for some time, and these are some of the common cases where we apply it: dysfunctional tear syndrome, persistent epithelial defect, recurrent corneal erosion, bullous keratopathy, filamentary keratitis. We also found it's more comfortable when you do edtachylation of a calcific band keratopathy. It also seems to help the wound healing of patients who've had a corneal transplant and some other indications. So this is a patient who had the amniotic membrane placed, and we normally see these patients a day or two later, and you can just to check the integrity of the amniotic membrane SCL complex, so you can see it's still intact. We've only had one patient where we had the contact lens displaced. This was someone with thyroid eye disease with extreme eyelid retraction, and we couldn't put the contact lens in a way that it wouldn't pop out when she blinked. So we referred her to one of our oculoplastic specialists for tarsorrhaphy. This is a patient who had a chemical injury. You can see the extensive amount of deepithelialization, and we did Wexel keratectomy and washed out the ocular surface. We put the epithelial side down amniotic membrane. Okay, so you can see some of the haze. But after a month, you can see that there's a very nice healing of the surface. Here's a patient with filamentary keratitis before the amniotic membrane. So we would remove this, do some keratectomy, and then we place the amniotic membrane and the soft contact lens, and you can see that there's full resolution of the filaments. This is a patient who had recurrent corneal erosion. She's had a previous ocular surgery, and after putting the amniotic membrane, the vision improved and the wound healed. Here's a patient who's been looking at the computer too much for a long time. So he's had florid SPK, and we put in the amniotic membrane with the bandage contact lens, and a month later, there's good resolution. This is a patient with pseudophakic bullous keratopathy, and you can see the epithelial defect here, making the eye uncomfortable. And after putting the amniotic membrane, you can see the defect resolved and the patient was relieved of her discomfort. It's important also to note here that it's not just putting the membrane, you also want to try to treat the original condition that led to the ocular surface disease. For example, in this case, the patient was encouraged to do aggressive lubrication as well. So aside from putting the membrane, you have to also treat the underlying disease. So this is a patient with a recurrent corneal erosion. You can see the eroded area down here. Her vision was good, but she was very uncomfortable. Um, and despite all of the aggressive lubrication, it wouldn't heal. So we put in an amniotic membrane, and you can see after 2 weeks, the patient came back. We removed the membrane, and it had healed completely. Some patients, they would actually have a blurred vision because of their ocular surface disease. Like this patient with recurrent corneal erosion, you can see that there was very bad irregular astigmatism caused by the irregularity of your corneal surface. But after treatment with the amniotic membrane, you can see that the irregular astigmatism went down and the patient's visual acuity improved. Here's another patient who had persistent dry eye and recurrent epithelial defects because of chronic soft contact lens use. And after the amniotic membrane, you can see resolution of the irregularity on the corneal surface. And you can see that her irregular astigmatism, which used to be 0.49 before the amniotic membrane, afterwards, with removal of the amniotic membrane and lubrication, the HOA dropped to 0.126. So we see that for a lot of the symptoms of ocular surface disease, applying the amniotic membrane results in improvement. Sometimes it doesn't work so well for patients with filaments and with stromal infiltrates, but for all the other indications, conjunctival inflammation, eye discharge, SPK, epithelial defects, especially soft contact lens complications, and we can see improvement of the patient's symptoms. Post-surgical, after amniotic membrane implantation, the pain and photophobia also decreased, and vision tends to increase. So in summary, for this part, ocular surface disease is blinding, painful, disabling, and despite the best medical treatment, the patients may not be happy. And this is where it's nice to be able to deploy the dehydrated amniotic membrane, which could help alter the ocular surface and make the conditions favorable for wound healing. In this part of the world, Indonesia, Philippines, we see a lot of patients with pterygium, and this is the other big set of indications for using amniotic membranes. We won't talk too much about this, but I think every day we see patients with pterygium, and the main problem with pterygium is removing its recurrence. And one way, of course, is to do a conjunctival autograft. The problem with conjunctival autograft is that you would have to harvest the conjunctiva, and theoretically, we like to avoid creating a trauma to another part of the eye, especially for those glaucoma specialists. If you work with a glaucoma specialist, they're not too happy when you've excised the conjunctiva superiorly, because this makes it harder for them to do a trabeculectomy in the future. Also, when you use a conjunctival autograft, you have to, if you have glue, then that's fine. But if you don't, you have to suture it on. So with a lot of sutures, and this takes time, and the patients are uncomfortable. So the good thing with autograft use is that you actually decrease the recurrence rate. But an alternative to using conjunctival autograft is to use the amniotic membrane. So you can use the amniotic membrane P, which comes in a large rectangular piece, and you can fashion a piece just big enough to cover both the corneal defect caused by the pterygium removal. This is usually where most of the pain comes from when you've had pterygium surgery. So if you can cover the corneal defect with the amniotic membrane and extend that amniotic membrane process post-op inflammation. To be more patient for also lower the recurrence rate. So we normally affix the scleral side of the conjunctiva by putting in one or two wing type sutures, but you can also use fibrin glue to attach the conjunctiva over this amniotic ring. And for the corneal component of the amniotic, the part that's covering the corneal defect, you can use the same bandage contact lens to hold it in place. So here, sometimes you get put the conjunctiva or amniotic membrane to hold it in place. And we found that this serves as a valent adjunct to prevent recurrence of pterygium. Looking at about 50 eyes where we did a pterygium surgery, we found the recurrence rate of only about 7%, and I believe this is very low. You probably would get less recurrence if you use the
I think we may have lost Harvey there for a moment.
okay.
Here he is.
There we are.
Were we in the pterygium portion?
Yeah.
Okay. Yeah, so I was saying that if you use the conjunctival autograft, you may have a lower recurrence rate compared to using amniotic membrane, but I think for all the benefits of the amniotic membrane, preventing an additional wound when you harvest the conjunctival autograft, speed of the surgery, you just actually have to put the amniotic membrane onto the scleral defect. You don't have to harvest a graft, so you can do this surgery much more faster. The lack of need for extensive suturing, giving patients a lot of comfort after the surgery, and also the ability to simultaneously cover the scleral defect as well as the corneal defect, I think greatly enhances patient comfort after surgery. And we've never seen any adverse events from using this technique. Okay, so in summary, for pterygium surgery, you can lessen discomfort using amniotic membranes. The occurrence rate is lower compared to bare sclera technique. And if you don't like to harvest the conjunctival autograft for whatever reason, I think this is a decent alternative method. Your surgery will be faster and it will be effective in preventing a recurrence. Okay, so I'm not a glaucoma specialist, but I'd just like to share some experiences from some of our glaucoma colleagues. So you can use the amniotic membrane for covering glaucoma drainage device or tubes that actually erode, and for doing bleb revision. And this has been reported in literature. And one of our colleagues, Dr. Robert Wecker, was kind enough to show this share this video of using amniotic membranes for glaucoma surgery. So you can see here this patient with the drainage tube up here, and he's freed the, and I think it eroded, so he's freed the overlying conjunctiva, and he's made these multiple folds of amniotic membrane, the dehydrated amniotic membrane, to cover that tube. Okay, and then he applies fibrin glue here, and then he can glue the conjunctiva over the amniotic membrane over the tube. It's an alternative to using for example, a pericardial tissue or a sclera. Okay, and as some of you know, I also I mainly do retina work, and I think this is one of the game changers in macular hole treatment. We can now use amniotic membranes to cover these macular holes, specifically for holes which are complex. Okay, so a macular hole will close better if it's smaller, and conversely, if it's larger, it's harder to close that hole. Other factors that lead to decreased prognosis is traumatic holes, holes that are recurrent, and retina surgeons, we like to use these adjuncts. Lately, using internal limiting membranes to cover or patch the holes have been quite popular. You can also use autologous blood or autologous retina. But recently, amniotic membrane patches or plugs have also become popular for closing macular holes and increasing the rate of success of complex macular holes. So this is a 71-year-old case with this lamellar macular hole here. And I would just demonstrate the technique that we use to use amniotic membranes to cover that hole. So as you know, the amniotic membrane is translucent, so we stain it with the brilliant blue-green, which you'll use anyway for retina surgery. And after doing a fluid air exchange, we can put the amniotic membrane onto the water air interface, and we can use either a soft tip cannula or a retinal forceps to guide the amniotic membrane over the hole. So because you've stained it, it's clearly visible. And once you put it over the hole, you increase the chance of macular hole closure. So you can see here post-op the patch over the hole. And if you do OCT, you can see this what we call the pigtail sign, demonstrating that the hole is closed and that the amniotic membrane is overlying the hole. So this seems to work for patients with complex holes. And we've done this in several procedures successfully. Another very complex type of macular hole is holes associated with pathologic myopia, very long eyeballs. So you can see here a patient that I wouldn't wish on anyone. He had a very large macular hole, 1.6 millimeters. It's a pathologic myopic eye. You can see how big that hole is, almost about the size of the disc actually. And what we did is we applied the amniotic membrane patch. And for these eyes with pathologic myopia, we would actually use a larger piece, and we would put autologous blood in front of the patch so that it will help the patch stick in place. And here we put silicone oil to tamponade on the hole and keep the patch in place. And you can see here on the top right, this is like a month after the surgery. You can see a closure of the hole with some of the amniotic membrane remnants. So in conclusion, the dehydrated amniotic membrane grafts show excellent biocompatibility, whether it's on the ocular surface or inside the eye on the retina. For ocular surface disease, it promotes wound healing and restores patient comfort. It's easy to use. We have a couple of clinics, and we stock it in both clinics because you never tell when a patient will come in. If you have an extensive pterygium practice, it should help decrease the recurrence rates of your pterygium surgery. And I'm sure a lot of inventive doctors such as yourselves will find more uses for this product. So thank you very much for your kind attention.
Great. Thank you, Dr. Harvey. Always great to see your lectures. Thank you, Dr. Michael. If you have questions for Dr. Harvey, you can write them or you can unmute yourself and ask them.
That was an absolute fantastic talk. I really love that. Is there anything you can't do with amnion?
Well, with Jay's imagination, probably not.
That's just fantastic.
Not me, doctor, it's you.
So when you were using it for Pterygium, do you have any tips and tricks for me and the audience when you use it for Pterygium? I did love your tip about covering the cornea, the defect as well, and I saw that you do anchor it in place with a couple of sutures.
Yes. Ideally, you should use fibrin glue.
Yes.
But maybe for cost considerations and also difficulty in sourcing fibrin glue in our practice, we figured the best way is just to put in 2 sutures on the 2 opposite corners to hold down the scleral portion of the amniotic membrane. The main thing is you should be pay attention to details and make sure that the corneal part of the amniotic membrane covers the entire corneal defect. And when you do that, patients are very comfortable after pterygium surgery.
That's absolutely fantastic. Great tips. And we have a question from Dr. Lowe asking you, how often do the patients follow up after putting the amniotic membrane over the epithelial defects?
So we usually see the patient a day or 2 after the procedure. Patients are also advised to call us if there's any problems. And the first or second post-op is just to make sure the amniotic membrane bandage contact lens complex is in place. We instruct patients that they should be careful when they're taking a bath, because some people, they like to take these showers, and we've had cases where the thing got washed off. So we advise them when they take a bath, they should close their eyes completely to prevent washing it off. And then a week later, 2 weeks later, 3 weeks later. So I agree with you that the amniotic membrane disappears generally after 3 weeks. All of them are gone. Some of them are gone after 2 weeks, at which point we can remove the bandage contact lens. So usually it will be removed either on the 2nd or 3rd week.
I think the size of the defect kind of determines that in most cases.
And how inflamed the eye is. If the eye is really inflamed, it'll eat it up quickly. Whereas if it's a non-inflamed eye, it can last a little bit longer. And I love the tip you gave, Harvey, about if you can spread the eyelids open with your fingers. I also do that because I do find that getting that speculum out is the trickiest part.
The hardest part.
Yeah, and if you can avoid that altogether, as you pointed out, then that's an excellent tip. Have you ever had one of those scroll up on you because you didn't dry the surface enough?
Yeah, there's a tendency to scroll up, so we just learn to do it quickly. Yeah.
Yes. So I would probably say to everyone in the audience, don't get discouraged if that happens. You can also just place the scrolled up amnion on a sterile environment and use 2 curved forceps to kind of flatten it back out. And if it does happen, you just remember that you probably didn't have the surface dry enough, or you didn't dry the bandage contact lens enough. Would you agree with that, Harvey? Do you also dry your bandage contact lens before placing it on, or? Yes,
I have the nurse dry it for me. Yeah, there's a question here about using mitomycin C. So it's our practice to use mitomycin C also to lessen the rate of pterygium recurrence. So make sure you wash off the mitomycin C completely and then dry the ocular surface before applying the amniotic membrane and the bandage lens.
Right.
It's a fantastic talk. I really enjoyed it.
Thank you.